Good evening, everyone. My name is Biljana Jovanovic, for those who don't know me. I'm IGA chair and also Gaucher patient from Serbia. Before we start, please use interpretation button because this webinar will be interpreted to four languages: Spanish, Italian, French, and German. Welcome again to the LEAP-2 mono trial for type 3 Gaucher disease, building on scientific foundations, phase 2 trial results and study design. We are very glad to have Dr. Pramod Mistry today to give 40 minutes presentation. Thank you so much for this. And then we will have a Q&A session. So please, if you have any questions, use Q&A button and box and answer your question. Give your questions. All questions will be answered, but please note that we cannot repeat or answer any questions containing sensitive information or patient-specific information. Our speaker today, as I said, is Pramod Mistry. He graduated MD, PhD from the University of London and rose through the ranks to become an honorary consultant and senior lecturer in medicine and founding director of the Royal Free Hospital, SPRA Regional Center for Gaucher disease. For the past 30 years, Dr. Mistry has been dedicated to advancing the care of Gaucher disease patients through cutting-edge research. He has helped build centers for Gaucher disease worldwide and is the chairman of Project Hope Humanitarian Program for Gaucher disease and the International Gaucher Disease Registry, ICGG. His lab has made sustained contributions toward discovering biomarkers, understanding mechanisms of Gaucher disease, and the genetic underpinning of highly variable patterns of type 3 Gaucher disease. He sees Gaucher disease patients in 3 locations in New York and Connecticut. Dr. Pramod Mistry, thank you again, and you can start.
Biljana, thank you so much for your kind introduction. And I want to thank you and Tanya and the entire International Gaucher Alliance team for their powerful advocacy and all that you do on behalf of the Gaucher community. I'm going to be talking, as Biljana mentioned, on type 3 Gaucher disease and a very exciting new clinical trial that has taken many years to get to this point. And so whenever we test a drug in a patient, it has to stand on the shoulders of scientific foundations, safety as we know it, as well as an earlier trial called the phase 2 trial, where everyone who is studied takes the medicine. So there is no double-blind period. And I'm going to be describing all of that today before I describe the design of the LEAP-2 mono trial. And so these are my disclosures. I do receive a research grant from Sanofi, and I'm a principal investigator in LEAP-2 mono trial. I'm a professor of medicine at Yale School of Medicine in Connecticut. So the members of our Gaucher community who are with us today don't need any introduction to Gaucher disease. We know that it is due to deficiency of this enzyme that leads to the buildup of a lipid called glucoceramide, this lipid, that builds up in the lysosomes of cells, shown here. And when we look at a bone marrow or a liver biopsy under the microscope, these are the Gaucher cells we see. These are macrophages that are engorged with lysosomes that contain this lipid. And so the defect in this enzyme activity leads to the buildup of this lipid. However, this lipid is very important. It's much like cholesterol in the body. So there is a way to make that lipid, starting with the building blocks, glucose and ceramide, which is a special kind of lipid, via another enzyme called glucosylceramide synthase to make glucosylceramide, and that in turn acts as a building block for more complex glycolipids, glycosphingolipids that have glucose, and this lipid called ceramide, which is an unusual lipid of a fatty acyl chain, and another lipid called sphingosine. You all know the manifestations of Gaucher disease. Many families joining today have been living with it, and so you don't need any introduction to it. So these are the manifestations of type 1 Gaucher disease. And in type 3 Gaucher disease, there is a variety of neurological symptoms, including eye movement abnormalities, difficulty in balance, and the technical name for that is ataxia, or feeling very stiff, and more advanced version of that is a myoclonus and even seizures and continuous tremor. The defining clinical sign of type 3 Gaucher disease is this, so that under normal circumstances, we can move our eye this way in a smooth way to follow an object. But in type 3 Gaucher disease, that coordinated movement is impaired. And so the eye, the pupil kind of makes a trajectory with an upward looping, as shown here. And this sign is called horizontal saccades. And in the beginning, it just looks like a squint. I know that some of you have had your loved ones who were initially taken to an eye doctor for a squint. But this is how it appears in the very early stage, just like a squint. And when it progresses, it can be so severe that the eye just gets stuck in one position. And in order to look at an object, the whole head has to move back and forth, giving this classical jerky type of movements. So in the International Gaucher Registry, Dr. Tilke Szymanski and others, Dr. Kolodny, as well as Dr. Volody, did a study to look at some 250 patients in the registry to understand what is the range of neurological signs that occur when brain health is affected in Gaucher disease type 3. And these are the technical names, but let me show you what are the big ticket items that we need to keep in mind. So generally, somebody with type 3 Gaucher disease have all the classic symptoms of Gaucher disease with big liver, big spleen, bone symptoms, low blood counts. And in the new generation of patients, everybody goes on enzyme replacement therapy, and the child is restored to health. And around this time also, the eye movement abnormality starts to take place. Along the way, in type 3 Gaucher disease, there may be evidence of impaired milestones, and the child can exhibit signs of autism, and that can manifest in a variety of ways, including extremely high-performing child with IQ in 140 range, but having quite disabling symptoms of autism. And all of this progresses over time to the point that it becomes very difficult for the child even to move and take care and handle daily activities of living. And ultimately, the saddest aspect is that all of this can progress to seizures and complete disability. So these are the signs when brain health is affected in type 3 Gaucher disease. So I promise I'm not going to put complicated pictures or data about the science, because you're not interested in this. You want to understand how we can conquer the effects of type 3 Gaucher disease in you or your loved one. But there is an important concept here that I think many of you will understand. We know that Gaucher disease is more than just buildup of the lipids, the fatty substances in Gaucher cells. What we have learned is that Gaucher lipids actually trigger the whole of the immune system, much as viruses do. But the difference is there is no virus. It is the Gaucher lipid that is causing inflammation. And this inflammation can be like a flu infection or the type that people with rheumatoid arthritis have. Just continuous feeling of tiredness and lack of energy because the immune system is in an overdrive. When people feel achy, have no energy, get exhausted very easily. And that is because the whole of the immune system is activated by Gaucher cells, Gaucher lipids. We also know that as this immune system is activated, our immune system builds antibodies to the Gaucher lipids. So just like we make antibodies to COVID virus, in Gaucher disease, our bodies make antibodies to the lipids, the fatty substance that builds up in Gaucher disease. And so this is what we call sterile inflammation because there is no infection. But what we've learned in the recent years through work in my lab and others is that these immune complexes, when the antibodies bind to Gaucher lipids, such as lyso-GD1 or lyso-GL1, then it goes back to the Gaucher cells and it binds to the immunoglobulin receptors. And one of its effects is to activate the complement pathway. And the effect of the complement activation is paradoxically, it increases the production of Gaucher lipid. And that is something that happens in any inflammation. So we've got this terrible feed-forward situation. On the one hand, there is a defect in a breakdown of Gaucher lipids. And because of the inflammation, the body is making more of the Gaucher lipid that leads to the amplification of the disease. And so when to treat enzyme deficiency, we give enzyme infusions and GCS, this enzyme that increases the production of Gaucher lipid is the target of substrate reduction therapy. And so, as I mentioned, the Gaucher lipids are important. So in health, the synthesis is balanced by degradation. And in Gaucher disease, synthesis is also increased because of inflammation, and there is a defect in degradation, and so the lipid is accumulating. And therefore, when you give enzyme, it gets to the macrophages in the body and then restores an equilibrium. With substrate reduction therapy, you have the ability to reduce the rate of synthesis that balance the degradative capacity, achieving a new equilibrium in the body. So enzyme replacement therapy is targeted to the macrophages, Gaucher cells in the body, whereas substrate reduction therapy is a small molecule. Its molecular weight is only 250 compared to enzyme, which has 250,000 molecular weight. And therefore, the small molecule can get to every part of the body where that needs treatment. And so substrate reduction therapy has the potential to cross blood-brain barrier. So Xadalga or Venglustat does not have the potential to cross the blood-brain barrier. And today I'm going to be talking about a version of substrate reduction therapy that does indeed cross the blood-brain barrier and improves brain health in Gaucher disease. Okay. So again, just to understand this condition, GL1 is a Gaucher lipid, and it is made by this enzyme called GL1 synthase, but it is also degraded by the enzyme to maintain a balance to produce glucose and this lipid that we call ceramide. And when there is enzyme deficiency because of mutations in the Gaucher gene, these lipids build up. And there are two main lipids. One is called GL1, and the other is called lyso-GL1 because the fatty acid has been removed from it. And this allows the cell to get rid of the Gaucher lipid, but this builds up in blood. This is the biomarker that we use. But you know, in Gaucher disease, it is the bad actor. This is the one that causes damage to cells. And this is what underlies all of the bad things that happen in Gaucher disease. And so these lipids build up in cells. You've seen these pictures many times before, and it leads to a child who is ill. And substrate reduction therapy is an inhibitor of this enzyme. You can think of it like a statin of Gaucher disease because the statins work in the same way to reduce blood cholesterol level. And so when we give Venglustat or Xarelto, it reduces GL1 production, and then treatment reverses the effects of Gaucher disease. And so until recently, children with type 3 Gaucher disease presented very, very sick. This is a picture of a child that I saw together with my colleagues in Egypt. You can see this child is dangerously ill, almost with a life-threatening situation, with massive liver spleen enlargement. The child is anemic and has severe failure to thrive. And this is after 14 years of enzyme replacement therapy, and this child is essentially restored to health. But eventually they go on to develop neurological signs. And we have a lot of data that shows that enzyme replacement therapy has been life-saving, but then as the child grows older, then the brain health becomes a major issue in their functioning. And so there are two types of treatment, as I mentioned. One is the enzyme replacement therapy, which is we infuse genetically engineered enzyme. The other is substrate reduction therapy, and this is the molecule picture. And what these technical numbers mean is that it is a very specific inhibitor. Unlike some other SRTs that have been developed, where they are in fact stronger inhibitors for other enzymes in the body and cause side effects. And so one of the advantages we have of substrate reduction therapy concept in Gaucher disease is that Xarelto or Venglustat is a first-line approved drug in type 1 Gaucher disease. And this was tested over many years, and these are data going out to nearly 10 years in the two trials, the placebo-controlled trial and the phase 2 trial. And you can see there was a dramatic effect just with that one medicine, oral pill, of reduction of liver and spleen size and improvement of blood counts. She's seen in both of those trials. And this happened after only having the oral pill, no enzyme given before or after treatment. And this tells us that this concept of substrate reduction therapy is a really powerful target, if you like, to reduce the production of this lipid in the body. And this is something that is well tolerated because we have data in many hundreds of patients over the last 20, almost 18 years. Now, I tell my students when I go to the clinic that you see so many miracles of modern medicine in Gaucher disease, but there's a very sobering statistics, because all of those miracles are in the European-centric view of Gaucher disease that usually includes one variant called the N370S, a founder mutation, which arose in Eastern Europe. What we've learned, in fact, there are many times more, maybe as many as 10 or 20 times more patients with type 3 Gaucher disease in the rest of the world. And we really must find a way to restore this large number of patients to health. And this is where the International Gaucher Alliance has been the most powerful advocates and champions for this underserved community, part of our Gaucher community around the world. So what are the steps to develop a new treatment for Gaucher disease? I showed you that the enzyme works really well, but these children have major issues with their brain health. When we develop a treatment, it is not just testing out the medicine in 5 or 10 patients, and then we get excited with the results. There's a very systematic approach, because that is the way we develop a drug that can truly transform lives of patients in our community who are affected by type 3 Gaucher disease. So first, and I'm going to describe all of these steps in a moment. First, we need to understand the science or the mechanism about how Gaucher lipids damage the brain. And we use mouse models of Gaucher disease type 3 in order to understand that. Second, we need a medicine that reaches the brain. So studies should show that the medicine is actually getting into the brain. And we need a medicine that is effective in other types of Gaucher disease. And that's where I mentioned that Cellular and Venglustat has really surprised everybody about how potent it is in reversing the effects of Gaucher disease type 1. Fourth, we need to understand the effect of medicine in a Gaucher mouse, okay? And then fifth, we have to understand that that medicine is safe, because that is first and foremost. We must develop a medicine that is safe to give to people. And sometimes we can have evidence of safety of the drug when it has been previously used in other types of diseases, and I will describe that to you as well. And then sixth, a phase 2 trial that I mentioned earlier, giving the medicine in an unblinded fashion to about a dozen or 24 people with type 3 Gaucher disease. And that was done, and it was called LEAP study. So all of these steps have been successfully completed, I guess, over the last 10 to 12 years, because it took a long time to develop the molecule, test it out in mice and so on, and do the LEAP study. And only if we can tick off all of these boxes, then the FDA and the European regulatory bodies will say, now you start the phase 3 trial of placebo-controlled trial. And this is the study that we'll be talking about, LEAP to Mono, which is, in my opinion, after 30 years of practice in this area, is the most promising opportunity, I think, based on all of these previous 6 milestones that have been achieved. So the brain health in Gaucher disease, the brain is a very, very complicated organ. You don't need me to tell you. But just to put this in context, in a mouse brain, there are about 70 million neurons. And it is not only neurons, there are other types of cells in the brain. Immune cells called microglia, then other cells called astrocytes, which nourish the whole brain. And these glia cells outnumber neurons by 10 to 1. So we need a medicine that is actually fixing the Gaucher defect in all these cell types, not only in one cells, or to deliver a medicine in one part of the brain and then hope by hit or miss some cells will be corrected. And given the technology of science that we have available to us, we can study the effect of Gaucher disease in these individual cells like the neurons, the astrocytes, and the microglia, and apply high technology approaches to understand how every cell in the body, in the brain, is affected by Gaucher disease. And we did that. I'm not going to show you the data, but I'm going to tell you the summary of hundreds of experiments that we did over a period of 3 years. What we learned that in fact just the inflammation that I showed you in the body with type 1 Gaucher disease, the same type of inflammation occurs in the brain. So there's inflammation in the brain, and we understand what are the bad actors in that, including these microglia cells. And when there is this inflammation, it then drives damage to the neurons. We also learned very important role of the brain immune cells called microglia, that if we fix the enzyme deficiency in the microglia, then we can significantly reduce the inflammation and neuronal injury. But when we give the substrate reduction therapy, we call it GZ161, it is very much like Venglustat. We can abrogate all of these damaging pathways and improve brain health. And so the key concepts here are that the Gaucher lipids stimulate the immune cells in the brain, causing brain inflammation. This causes malfunction and damage to neurons. And moreover, we can monitor brain disease by blood biomarkers shown here, such as the Gaucher lipids, neurofilament light, which is produced from damaged neurons, which we can measure in blood, as well as a protein called apolipoprotein E. And we have shown in these studies published recently that when we slow the production of Gaucher lipids, it reduces brain inflammation, and it also reduces damage to the neurons. Okay, so this is the medicine we are talking about, Venglustat. It's an inhibitor of this enzyme that is making glucosylceramide. And when we slow down the production of glucosylceramide, it reduces the buildup of glucosylceramide in Gaucher disease. And we have shown that in people with type 1 Gaucher disease, as I showed you, but also in type 3 Gaucher disease, as I'll start to share that data with you in a moment. So one of the big challenges in Gaucher disease is how type 3 Gaucher disease affects everyone differently, but everyone has this eye movement abnormality. And so a child could be severely disabled, not able to move independently, have seizures, and then some children just have the eye movement abnormality. So hopefully we are now coming to a time when no child is going to become disabled with neurological disease. That certainly is the goal of our Gaucher community. So here are the mouse data, and I promise you this will be the last mouse data that I'll show you. So this is a model of type 3 Gaucher disease, and you can see that these mice die very early. But when you give the Venglustat type of medicine that we call GZ161, these mice live in a normal way. Moreover, if you measure in blood this biomarker called neurofilament light, then it shows that you can track how badly the brain is damaged. And so this type of studies have yielded a very important biomarker. We've also learned that the Gaucher lipid, glucosylsphingosine, tracks very nicely with what is happening with regard to brain health. And moreover, inflammation in the brain goes down when we treat the mice with the Venglustat type of inhibitor called GD161. So now I come to phase 2 clinical trial, and that was called LEAP. Okay. So what we did in the LEAP study was this. We took adult patients with type 3 Gaucher disease. They were aged 18 or more, and 11 patients were recruited. They had all been stable on enzyme replacement therapy every 2 weeks, and that was continued. But we added Venglustat. We now just have a pill. It is not even a capsule, okay? And so at baseline, a number of objectives were pursued. First and foremost, always is safety and tolerability. And then we want to see that the medicine is actually getting to the brain and starting to show effects that we want it to. But then you also want to show how long does the medicine stay in blood, and whether there are some early indications that the medicine is actually working and helping these individuals. By the way, most of these individuals had severe type 3 Gaucher disease. So many had difficulty in ability to independently walk about and take care of themselves and so on. So these were very sick, sadly, individuals with type 3 Gaucher disease. So the first thing we found is that when we measured the blood samples after our patients took the medicine in the blood and also in the fluid bathing the brain called CSF, and that sample is obtained by a spinal tap. What we found is that not only does the medicine appear in blood, but it also appears in the brain. This is very important to show if we want a medicine that is going to improve brain health. Okay. Then what we found is that we measured when the patients were treated for a year, we wanted to measure whether the Gaucher lipids, we call them GL1, glucosylceramide, or lyso-GL1, glucosylsphingosine, it dropped in the CSF in 10 out of 11 patients. Also, there was a further decrease in blood in 10 out of 11 patients. This is very important finding because you would think if people have been on enzyme treatment for 10, 20 years, there's nothing more to improve. But there was, in fact, a greater improvement in these biomarkers of Gaucher disease. Then we did this test called SARA score. That is a way to capture in a numerical way how severe the disability in posture control and coordination is. And this is a scale that is widely used in medicine to understand the impact of disease and treatments. And so lower scores shows improvement. So here is this patient who had a score of 3 at 6 months fell to 1, and at 12 months, this person was able to walk completely normally, and you didn't see any abnormality. So this same kind of trends were seen in most of the patients, as you can see. Here is a dramatic improvement from 3.5 and 0 and 0 here as well. Okay, so this is the kind of phase 2 data that can be very encouraging for us to move forward with a medicine to test in a phase 3 trial. This is the trail making test. This is a very simple test. Everybody knows about it, but it actually captures some very refined neuronal pathways in the brain to see the integrity of the brain. And so a low score indicates an improvement. And so, for example, here is a patient who took 73 seconds to complete the trail making test, and it fell to 6. So there are quite a number of patients in whom the trail making test improved. Okay. And so we also in this study did a MRI to look at neuronal connections. It's a way that we can look at connectivity between different parts of the brain. So the resting state neuronal networks 1, 2, and 3 give us an idea about how perception, vision, cognition, language, and orthography and cognition is shaped in the brain. And the other networks like 6, 7, and 8 capture how we sense the environment, the sound, and the executive control. And what we found was there is increased functional connectivity, which was most prominent within the sensory, motor, and the cerebellar networks, which are primarily disrupted in Gaucher disease. And enhanced connectivity was seen at the level of functional resting state neuronal networks and anatomic structures. And there was increasing functional MRI signal coherence noted between systems level brain circuits underlying functional impairment. So the bottom line is that this kind of high-tech testing confirmed what our patients were experiencing in terms of improved evidence of brain health. And these are the kind of images that we get. These are the data at 26 weeks and at 52 weeks. And you see here, for example, yellow is good connections, and these are poor connections. And this improves quite markedly at 52 weeks of treatment. So something very fundamental is going on at the level of neurons and brain inflammation in Gaucher disease, in individuals with type 3 Gaucher disease. And so I think first and foremost is safety. And normally in our academic meetings, we don't present the data, we present safety first. And combination of ERT versus Venglustat was well tolerated and safe. There were no treatment-related side effects. The only thing we noted was there were headaches reported just on the first or second day after the spinal tap. So we are very fortunate in a way that we have evidence of use of this drug in another setting, and that is in the MOVE SPEEDY study, where people who didn't have Gaucher disease, but who were carriers of Gaucher disease and developed Parkinson's disease. And so, in that study, 111 patients were on placebo and 110 patients received Venglustat. And you can see that there is no difference between placebo and Venglustat in the side effects. It is this kind of data that gives one a lot of confidence that you are not going to turn up something completely unexpected when we treat patients in the phase 3 clinical trial with Venglustat. Okay. So the other thing to note is that although the biomarkers improved, we also found that the blood counts and the liver and spleen volumes remain normal. So in summary then, and this is the picture of the paper that was published just recently, at 1 year, we demonstrated that Venglustat crosses the blood-brain barrier. There is reduction of the Gaucher lipids in brain fluid, and there is potential to ameliorate neurological manifestations of type 3 Gaucher disease, and the functional MRI also improved connectivity and coordination between different regions of the brain, and it showed a favorable safety and tolerability, and the liver, spleen, and the blood counts remain stable. So now we come to lead to mono study that started this year, and it is an international double-blind, double-dummy clinical trial. And so the European regulatory authorities, as well as the US FDA, require this very high level of evidence in order to approve drugs. And rare diseases are no exceptions. So here, I think the first thing I would say is how important it is to take part in clinical trials and studies. Normally, a lot of us are isolated. We have our one dedicated doctor wherever we live, and we don't have the multidisciplinary care that is needed to keep us healthy. Taking part in a study allows you to get multidisciplinary and comprehensive care by an expert Gaucher disease doctor, as well as experienced subspecialties that involve other manifestations of Gaucher disease. The trial allows you support for travel for you and your loved one, and it allows you an opportunity to access the most up-to-date medicine at the earliest time, rather than waiting until the drug is approved. And none of this costs you anything, because our sponsor generously covers all the costs associated, including the medicine. And there's a commitment to continue the medicine until the medicine is approved wherever you live in the world. And this is a wonderful way for us to be part of the Gaucher community and help others, so that no future patients would come to the disability that we now recognize and take it for granted in type 3 Gaucher disease. So this is the design of the phase 3 trial. And these are individuals who have type 3 Gaucher disease. And we recruit children from age 12 to 18 and adults greater than 18 years old. And they have all been on enzyme replacement therapy and have been stable and achieved therapeutic goals. And we are going to evaluate them and then randomize them into either continue with Cerezyme, but take a placebo pill of Venglustat, or alternatively give them Venglustat and put them on placebo Cerezyme. And that will be for 12 months. And after that, everyone changes to Venglustat. Therefore, it is called leap to monotherapy. And so our confidence in going from combination from enzyme replacement therapy to monotherapy with the oral pill is a very systematic one. And it will allow us to truly, objectively, and scientifically capture the true effect of Venglustat on brain health. So these are some of the inclusion criteria, and your local doctor, or if you go to clinicaltrials.gov, it is all nicely described. You have to have stable Gaucher disease and at least 3 years of treatment. Obviously, have to have type 3 Gaucher disease with the eye movement abnormality, and so on. There are some exclusion criteria. There are rare individuals who have very severe liver disease, or who have so disabling seizure disorder that is not controlled. And at the present time, these individuals are not eligible to take part. And so initially, everybody will be on this double-blind period. They will either have a placebo of Venglustat or continue on enzyme replacement therapy. People will not know whether it is enzyme or just the placebo saline, because it will be covered in a green bag. And your doctor wouldn't know, nor would the nurse who is giving it to you. And then the other part will be those who are actually having Venglustat and they will have the placebo, just the saline infusion. That is for 1 year, and then everyone goes to the oral medication. So here are some of the details, and if you go on clinicaltrials.gov, this is all described, and an important feature is an essential inclusion criteria is the demonstration of this eye movement abnormality. Okay, so here are the primary objectives or the primary endpoints, because we are now in an era where it is not enough to say that the medicine is just improving your platelet counts by 20,000. What the regulatory authorities want to know is how is it helping the patient to improve better life. And so I described all the science, all the biomarkers. We are going to look at all of that. But ultimately, we want to see that patients with type 3 Gaucher disease are leading better quality of health than they were before. And in order to do this, the two primary endpoints are these. The SARA score that I described is your coordination improved. And then there is another test called the RBANS test, which checks immediate memory, visuospatial construction, language, attention, and delayed memory. These are actually very sophisticated tests that allows us to capture the function and health of many different regions of the brain. And so that is a high standard we have, because we don't want a medicine that just improves biomarker. We want a medicine that will truly make a difference to the quality of life of people with type 3 Gaucher disease in our community. These are some of the secondary objectives, and many of the scientific biomarkers and so on are included here. Of course, side effects will be captured very rigorously, and we see these individuals every 2 weeks or so. And these are some of the biomarkers. The neurofilament light chain that I mentioned will be checked in blood, as well as the biomarkers, and additional new biomarkers that are emerging will also be measured to try and get a handle on the health status of brain health in type 3 Gaucher disease. We will do some other exploratory endpoints, such as behavior scale or the depression and overall quality of life, the so-called patient-reported outcomes, which are again designed to improve the overall health rather than just improve a biomarker to make your doctor happy. Okay, so we will again measure the blood levels of Venglustat in blood as well as in spinal fluid to build on what we did previously. So I've gone over a lot of this very quickly, but it's all accessible online. And if anyone wants to get in touch with you, I can send you detailed information. So this is our Gaucher community is working together in this global effort. And you can see the countries that are taking part. And today, it's a European Gaucher community from Germany, Hungary, Italy, as well as France and United Kingdom that are joining us. And you can see the name of the doctors, expert doctors in your region of the world, including my colleague in United Kingdom, Professor Darylyn Hughes and Dr. Chakrapani, as well as colleagues in Germany, Hungary, Italy, where you can get in touch, and France to inquire about your eligibility to take part in this trial. So with that, I thank you, and I'd be happy to take any questions.
Thank you so much. We have questions. Just to say that we will upload this video and send the link to all who attended. And now, one of the questions is if the Venglustat is approved, will it be taken alongside ERT?
No. So the phase 2 clinical trial and what we have learned in the Venglustat trial, that substrate reduction therapy on its own is sufficient to control Gaucher disease. And so in this clinical trial, individuals will either continue on Cerezyme or another enzyme replacement therapy as long as they've achieved therapeutic goals, or if they are randomized to the other arm, they will have Venglustat, but they will not be having enzyme. It would just be a placebo infusion. But people will not know whether they are on placebo enzyme or a placebo Venglustat.
Okay, thank you. From Michaela Dan, thank you for your very clear presentation regarding the fact that SRT is working more slowly than ERT. Would you say that SRT should rather be reserved for less severely affected patients?
That's a very important question. And so, as I tried to explain in my presentation, we have almost 15 to 18 years of experience with Venglustat. And one of the most remarkable and unexpected finding is that SRT works as rapidly as enzyme. Everybody expected that the enzyme works very fast and SRT will take a long time to work. And that has been disproven. And so all of the data, even the phase 2 clinical trial data, have shown that there's a very rapid response of SRT. And that has been the foundation for the design of LEAP-2 Mono trial.
Another one, is there any exclusion criteria that could prevent a type 3 patient from using this drug, even if when it is approved by regulatory agencies?
Well, we have to wait and see at all of the data when the clinical trial is completed. But based on my knowledge of the science and the phase 2 trial and what I've seen with the Moose PD study, I don't see any major barriers for use of Venglustat in the future if it is approved in any type of type 3 Gaucher disease. There would not. So I mentioned, for example, that one of the exclusion criteria is the rare individuals who have very severe liver disease. Again, we need to understand that if there is liver disease, perhaps we might go with a lower dose, but that is a whole different topic for later discussion. The first thing is to show whether this medicine works. And I think it will, if it is approved, if the data really come out as we expect it to, then we would expect that we will be looking at what are the contraindications to it, or to its use, if any.
Thank you. Do we know more about what happens to ceramides resulting from inhibition by the SRT medication?
So the question is a very important one. And so the concept, just so that everyone understands what this questionnaire is asking, if you inhibit the production of glucosylceramide from ceramide and glucose, does that mean that ceramide is going to accumulate? And having an accumulation of ceramide is not a good thing because it's a toxic lipid. And this was examined in very great detail in all of the Venglustat trials. over 14 years in nearly almost 1,800 patient years of experience. And we measured ceramide levels in these patients, and there was no accumulation of ceramide. And one of the reasons for this is that the ceramide that arises in the cells have different pathways to regulate the level of this toxic lipid. And those alternative pathways kick in to maintain an equilibrium of ceramide. So there have been no events of ceramide accumulation that have been seen in any of the clinical trials. But in this study, for the sake of completeness, some of the exploratory biomarkers will be looking at this.
What if a patient is on different ERT drug, not Cerezyme? Are they still able to take part?
Yes, they are able to take part as long as it is an approved enzyme replacement therapy. As you know, that there is a enzyme replacement therapy called Epsertin that is not approved in many countries in the world. But as long as they are on one of the approved enzyme replacement therapies, such as Cerezyme or Vipri, and they've achieved their therapeutic goals, then they are eligible.
Thank you. So one from patient from the study, he is disappointed about how long it took to get to this point. So how long will it take to get the admission?
Yeah. So I think if the question is that it has taken such a long time, and you are right. I think I feel personally bad about it. I shared with you that there are many times more type 3 Gaucher disease patients in the world than type 1. And I think in many ways, I think sadly, type 3 Gaucher patients have been left behind, but no more. You know, there are many different exciting approaches, and I envision a future for people with type 3 Gaucher disease that will be a healthy future. People who will be able to do everything that anyone else aspires to. So that, I think you are right. You are absolutely right to challenge me on that. Why did it take so long? And I think it is very sad that we did not, as a Gaucher community, focus on this work, and in large measure, through the pioneering advocacy of International Gaucher Alliance, I think it has prompted, because you need big pharma to support this kind of effort. And it was International Gaucher Alliance and patients like you, the questionnaire, who has really prompted the pharmaceutical sponsors to really take on this challenge.
Thank you. And one more. Can a patient taking Ambroxol take part in the trial?
So currently, Ambroxol is a drug that is thought to work as a chemical chaperone. And if somebody is taking Ambroxol, the requirement is that they come off any kind of chemical chaperones for at least 6 months before they take part.
Thank you. So thank you so much for all your work and for this presentation, for your patience to answer the questions. I would like to thank you to all who participated, who attended this webinar. Once again, it is recorded and will be uploaded to our YouTube channel, and the link will be sent to all attendees. Also, we will send a short questionnaire, and I would like all of you to answer the questionnaire when you get it.
Biljana, one last. I think that there was a question about when will the trial start, and answer to that, it's already in progress. So I showed you the names of the sites that are approved, and you should get in touch with one of your nearest site to inquire about being evaluated. And another question, I'm sorry, Biljana, I hope I'm not.
I didn't. Yeah.
Another question was how often Venglustat is taken. It's taken once a day, and children have half a dose and adults have, I think, 14 milligrams per day. And yeah, and there was another important question. Is SRT selective on glucosylceramide synthase, and could it inhibit other enzyme? And the answer to that, it is highly selective. It is not inhibiting other enzymes. That's all.
Thank you. Thank you once again. Goodbye, everyone. See you